Thank you very much. I'm happy to be here, and I want to thank the Moroccan Society of Neurosurgery for inviting me, particularly Professor Absamad El-Wahabi. I'm very glad for this. So I wanted to talk about hydrocephalus. A lot has been said about hydrocephalus, but few theories concerning psychomotor disorders have been put forward. In the definition of hydrocephalus, the key word is ventricular dilation, sometimes associated with signs of intracranial hypertension, signs of transependymal resorption. The general definition of hydrocephalus is a clinical syndrome of intracranial hypertension by ventricular dilation related to resorption or circulation disorders in cerebrospinal fluid. This definition does not include psychomotor disturbance during hydrocephalus. So the key word is ventricular dilation. What are the mechanisms of this ventricular dilation? Is this ventricular dilation made in the same way and at the same time on each ventricular wall? How this knowledge can be used in the assessment of hydrocephalus, the endoscopic management, and the prognosis of patients? As I said, the key word is ventricular dilation. What data defended that psychomotor signs appear before intracranial signs in hydrocephalus? We are going to take the example of the dilation of third ventricle. What information third ventricle dilation gives in the evaluation of prognosis of hydrocephalus? We are going to use anatomical data, histologics, hydrodynamics, and to ask how could help this data to analyze differences in third ventricle dilation. We know, to remember the anatomic, the third ventricle have 4 recesses here, and neurosurgeons have not know very well about the roof of the third ventricle. Today we are going to talk about the roof of this third ventricle. You have to pay attention with this part, this little part about the velum interpositum system. And during the third ventricular dilation, this small space is the seat of multiple modifications going as far as rupture. What explains this? You can see in our all experience that the roof going to rupture. Only we have rupture on the roof, not in the seat of anterior cistern or posterior cistern or in the flower of the third ventricle. Why this rupture occurs only through the roof? You can see in the anterior part recess, posterior part recess, and in the flower of the third ventricle, you can have distension, but not rupture. Change that can go as far as rupture appear early after the third ventricle dilation. As you can see, after 3 hours, when you inject even blue dye, after obstruction of the third ventricle, the contrast appear after 3 hours only in the roof of the third ventricle, not in the anterior part, in the flower and in the posterior recess. During the third ventricular dilation, the anterior and posterior ratio distended, but rupture is exceptional, as you can see here. You can see the bulging, the bowing of the anterior part, the flower, and the posterior part only. But we have some exceptions. It was reported in the literature 5 cases of rupture of the ependymal part of the third ventricle, not only in the roof of the third ventricle. Apart these exceptions, anterior and posterior recesses distended without rupture, but the roof distended and rupture. I hope that this video will work. It's not working. This video shows us how the importance of the distending of the flower of the third ventricle. It can go through the foramen magnum, but never rupture. The histologic and hydrodynamic data contribute to the understanding of these findings. Histologic data shows us the recess, the flower, and the lamina termini as made of ependymal tissue. But the roof of the third ventricle is made by tela choroidea, which is conjunctive tissues. The ependymal epithelium have 2 details. The first detail is that little or not basal membrane. Sometimes there is no, many times there is no basal membrane, and the zonular adherents are distensible. So this ependymal characteristics make the epithelium ependymal going distending without rupture. And but at the roof of the third ventricle, because it's a conjunctive tissue, it can go to rupture. So after this histologic data, we have also hydrodynamic data. The movements of the ependymal membrane undergoing low amplitude fluid displacement increase ependymal elasticity. So, what is the point of remembering that? The modification of the roof of third ventricle belonging to the limbic system appears early during ventricular dilation. It is for the demonstration that psychomotor disorders appears before intraocular hypertension signs during hydrocephaly. It is also for the demonstration that in case of rupture of the roof of the third ventricle, psychomotor disorders not disappear despite the reduction of ventricular dilatation after shunt of ATV. It is for the demonstration that analysis of the roof of the third ventricle, in particular the velum interpositum system, must be integrated during evaluation of cognitive disorders during hydrocephaly. We perform a retrospective study in our center during the 5 last years. The objective was to realize endoscopic anatomy review in the third ventricular roof of our patient, to discuss the technique and the interest of the third ventricle flower coagulation for bowing reduction, and to suggest an evolutive classification of the third ventricular roof modifications during hydrocephaly. We reported 167 ETV case in 5 years about third ventricle flower herniation. We have 34 cases of third ventricle herniation going to the foramen magnum, and 128 cases of first ventricle flower herniated below the clavus, and 4 cases only of third ventricle descending at the level of the clavus, and for the patients which have herniated going to foramen magnum, we perform coagulation of the fourth ventricle to reduce the herniation. And for patient, for only for 31 cases, the coagulation for reduction was made to intentionally to reduce the herniation of the flower of third ventricle. Here, the example. I think that the video is not working, but it shows that when we have the herniation of the flow of the ventricle, when you coagulate the flow of fourth ventricle, of third ventricle, you can have reduction of the bowing. But about the roof of the third ventricle, and on all our cases in 5 years, we discover that our videos explore only 76 video, all the roof of the third ventricle. And it's only 45% of cases. Few endoscopic studies about the flower of third ventricle, the modification of the third ventricle roof during hydrocephalus. We can report this study from Zodi. In this study, it's described the modification of the roof of the third ventricle, but it's not a evolutive classification. Most of studies are talking about the roof of the third ventricle because it's only reported cases of velum interpositum cystic. If you look this classification of Zodi, we have the 4 types of modifications of the roof of the third ventricle. But this classification is not an evolutive classification. And as we can see in this image from Zodi, we can have many kinds of modification of the flower of the roof of the third ventricle, but all modifications concern destruction and rupture of this roof of third ventricle. In our study regarding to this classification, we have this always in 94% of patients always destruction and rupture of the layers of the roof of third ventricle. As we can see on this video images, we have always destruction of the flower, the roof of the third ventricle. So we think that the rupture of the roof of third ventricle is not the first state. It is the last state. For us, the first state is the reverse in the normal curvature of the velum interpositum. And on MRI, we can see this system of the velum interpositum. The modification of this system of velum interpositum for us is the first state when we have dilation of third ventricle. And the second state for us is the reverse of the triangular shape of the velum interpositum with change in size and spacing of the body of fornix. And on MRI, we can't visualize the internal cerebral veins. And the third state is a rupture of the roof of the third ventricle. So we think that evaluation of the velum interpositum system can lead us to detect any modification of the roof of third ventricle. This can help during evaluation of any cognitive disturbance. This can help during evaluation of cognitive status. During correct cognitive evaluation of the normal pressure hydrocephalus in the same time of events index evaluation, during the evaluation of memory disturbance, during evaluation of demences, during psychomotor test, and during QE test 2, and during job interviews. We think that the modification of velum interposition system is an early sign of cerebrospinal fluid disorders. We know that we need additional studies and concerning MRI measurements of velum interposition system in cognitive disturbance. We need more study to know what is a part of psychomotor disorders during the evaluation of hydrocephalus chronic in the adult. Thank you very much.
Thank you very much, Professor Sanusi, for this interesting paper. Maybe we can discuss at the end when the other paper has been presented. Would you please present the second? Okay, good. The next presenter is Professor Ashuri, who is going to talk about craniosynostosis, spectrum of conventional techniques. Please, Professor Ashuri, go ahead. Sorry, I made a mistake. It's Professor Shilawi replacing Professor Ashuri. Please, Professor Shilawi.
Good evening, everybody. So on behalf of Professor Ashuri, I would like to apologize for him because he can't, for a problem of flight issue, he can't be among us. Okay, so my talk will be about craniosynostosis. As you know, craniosynostosis is a malformative disease which correspond to a precocious views of different suture. It accounts about one case for 2,500 births annually. We have two types of craniosynostosis. This is the primary craniosynostosis, which correspond to a fuse of one or more suture, which accounts for 80% of all the diseases. And we have also complex craniosynostosis, which correspond to syndromic craniosynostosis with the many diseases called Pfeiffer, Appert, and Cruzon. This disease is a challenge, and this is why, because it will happen in a pediatric environment, which requires a lot of good pattern to succeed, to have good results. Also, this is a stressful surgery because of the age of the babies, because the babies, they have a small volume of blood, which corresponds about approximately to 100, sometimes less of milliliter. So we have to preserve this blood. Also, the anesthesiology for this pediatric trench is very challenging, and also because we have many malformation associated, like the respiratory tract. So all these patterns lead to a difficult management of the sort of disease. So all began with this disappear of these women who asked Dr. Elsie Lane, professor of surgery at Cooper Medical College in San Francisco, why couldn't you unlock the brain of my candidate's child and release it to grow? Realized in the 80s, the first operation was realized in the 80th century and described the early stenosis in the literature. Below you have many illustrations that represent a sort of heritage in our department. It would provided by Dr. Aqua, who was a French neurosurgeon, the first who founded the first department in Casablanca, and he had made many publications about the subject in the literature. So in our department, from 2010 to 2017, we operate about 120 maybe. If we take a look at the series, the French series, which began from the 1988, they are almost because they have two famous centers to do this sort of surgery, which is Necker in Paris, and of course the other hospital in the south of France, which is Marseille. Professor Ashouri was the first, was the pioneer, if you want, of this surgery in our department, because he made his fellowship in Marseille with Professor Schooks, and then learned a lot of techniques and was very involved in this surgery. And we have the opportunity to learn with him and to vary our techniques. So what are the goals of surgery? Of course, the first goal is to achieve a cranial decompression, because if we, without surgery, if we delay surgery, the development, the growth of the brain will be compromised. And of course, with the rising ICP, it will be a papilledema, and then it may be lead to an optic atrophy and then a blindness. Also, the other argument now in the literature is the difference between the patients who will be operated. They will have a good outcome concerning the cognitive future, and then the difference will be noticed, especially for the verbal comprehension, the verbal conception, reasoning, vocabulary, and comprehension of social situation, which will lead to a good scholarship. Also, the other argument is to do the morphological correction. The cosmetic correction is very important for this pediatric tranche of patients. Also, the scaphocephaly, the trigonocephaly, and of course plagiocephaly affects deeply the face of the young babies. Donc a deformed head is a disgrace and social disability. And then you know that the face is a sort of passport in our social integration with others and inside the society. So no pediatric children suffer from the handicap at the first time of their scholarship and will be isolated within their classmates. But while when the deformation is minor, the surgical abstention is the rule, and now we can also suggest the other therapeutic like the helmet orthosis, and maybe sometimes just to wait and see and follow the evolution and the growth of these patients. Of course, the goal also is to, especially in syndromic craniostosis, You have many facial deformity associated with frontal disability that oblige us to do something for us. And the technique is to do a cut in the frontoorbital bone duct associated with an advancement of the frontal lobe. Because if we don't operate this pediatric trench, will have many respiration issue, phonation issue, mastication problem, and even ocular ulceration due to the exaggerated proptosis. So when to go on surgery? The best to go on surgery, for example, for scaphocephaly is 1 month, but it's not always permitted to do it, especially when you have to convince the anesthesiologist, because at this age is very difficult to monitoring this tranche of age. But we could perform a clavier reconstruction from 9 months. Surgery could be performed even from the birth if you have a good staff of anesthesiologists and maybe maxillofacial with you. Surgery consisting on frontoorbital remodeling is indicated for brachycephaly, plagiocephaly, trigonocephaly. And the best time to perform it is at 6 months, but you can tolerate from 9 to 1 year. At this age, bone is very malleable, it's very soft, you can cut, you can translate, you can do like an artist, do the best thing for these children. After 2 years, all the results are uncertain, and the bone became very hard to cut and to control. So what are the risks that you have to explain to the couple, to the mother, because this challenging surgery, you will have always the challenge to explain to a young couple, to convince the mother of the utility of this operation and the result that will be unsure after. So the bleeding is the main problem and the main risk for this surgery, especially some sort of craniostomies like scaphocephaly, where there is a lot of cut of bones and displacement of bones. So very common in craniofacial reconstruction, because the volume of the blood is at this age is really very limited, small. It's about 100 milliliters. So you have to manage this and to keep this in mind. Of course, we'll have also a problem of babies cooling. So you have to make some mattress warming, to speak to the anesthesiologist to keep this child very warming in order to have a best post-operative course. Of course, we'll have also some wound cicatrization delay if the intervention will lasted more than 4 hours or to 5 hours. You will have some reossification, some precoce reossification problems also, infection, and sometimes you have some displacement or dismantling flaps that require a re-intervention. So what are the different complications that we have? So we have one case of CSF lake, especially in a 4 years old child with scaphocephaly, which necessitates an reoperation, one case of meningitis, and one CSF effusion to the scalp in 2 cases. So what are the different techniques? Especially for scaphocephaly, we have 5 conventional techniques and more. It depends on the argument and the customs of the surgeon. So you can do unband craniectomy and vulvar sagittal suture, craniectomy in railway on the 2 sides of the sagittal suture. You can have generous or large craniectomy involving sagittal suture with anterior and posterior extent. And you can also have a P procedure in this craniectomy. In some cases, what we did for this scaphocephaly, this is craniectomy, interparietal craniectomy. You notice also the skin incision in zigzag, not vitragal. Same technique, and when you test the picture below, the infant is beginning to gain an enlargement of the head. Now maybe a few months later, we have the best correction of this scaphocephaly. But now the new things, the new technique is the endoscopic technique, which is really very well indicated at the infants, which the age is inferior to 3 months. There is less blood lost, and it's very reliable technique, and it lasts a few hours. Alors, the trichinocephaly, generally we cut the frontal bone flap to take a temporal part in order to avoid the temporal hollow, which is a minor inconvenience for this surgery. We advance the external orbitalis cornea to correct the exorbitism, and sometimes we have to put what we call the wedge or piece of bone just to open the angle and to correct the hypoterrorism. Some demonstrative cases. Brachycephaly is a vertical and remote front, so we have to perform a cut of the frontal bone and the front orbital bundle, and then to move all these pieces forward by 2 centimeters and fix the bundle front orbiter to the facial complex. Some demonstrative cases also. So plagiocephaly gives an aspect of asymmetric face. The frontal bundle should be moved and lowered on synosthetic side. We can do it unilateral or bilateral, and donc when we have to reach a symmetric aspect. This is a plagiocephaly, left plagiocephaly, correct? So in asymmetric fashion. So oxycephaly is more complex, and then we have to correct by obtain the advances of the superior part of the orbit and frontal correction, and then fix the bundle frontal orbital to the maxillofacial part. For the syndromic craniostenosis, almost this is a genetic disease, justifying a specialized advice. Management should be done with multidisciplinary medical staff, especially with maxillofacial, because this is a problem also with the maxillofacial block. The medical staff should gather many specialists well trained and competent. So the result in 90%, we have good reduction of the dysmorphy. At long term, 80% had normal scholarship. This is a good achievement. The surgical treatment doesn't represent only an aesthetic issue. So in conclusion, the craniostenosis encompasses many diseases with variable morphologic and critical points. An effort must be done to achieve an early diagnosis for a best management, which will be performed at the early stage of life with a well-trained and competent team. So this is some cases operated by my colleague, Professor Ashori, and you know that there is a lot of joy on their face. Thank you.
Thank you very much for this fantastic paper. Would you like to answer some questions now? Or would you like to present?
This is my last comment.
You have to present?
This is the last communication.
That's last communication?
Maybe.
Okay.
Adi.
Professor Darak, is Professor Darak presenting? Or our colleague from Ethiopia?
So we call Professor XIIIth prevalence and treatment outcome of NTD in Ethiopia, challenge and opportunity. It's not here. Darak? Yes. So we call Professor Darak from Sudan to speak about management of pediatric brain tumors.
Thankful for Moroccan colleagues for the invitation, and I like to come here and feeling that I am in my country and between my family and colleagues. So thank you for that invitation. I'm going to speak about our experience in Sudan in managing pediatric brain tumors. They are well-known conditions of morbidity and mortality in the pediatric group, because we know that 20% of the tumors affect the pediatric group, and this is the most common problem that will be met by the neurosurgeon in the pediatric group, besides the hydrocephalus and trauma and congenital malformations. So is considered as the main cause of mortality in the young children. It only preceded by hemolytic malignancies, and dramatic improvement has been achieved in the survival and in children and young adolescent cancer. In this study, we aim at scheduling the lives on different pattern presentations of Sudanese children presenting with brain tumors, reflecting the experience of the National Center for Neurological Sciences in Sudan in setting strategies for the management and long-term follow-up. This study may be extending to 14 years or more even. A total of 54 patients were studied or included in this study, and this presents the clinical features of the patients, which is usually headache in older children, but failure to thrive and loss of consciousness or blurring vision, vomiting, all features and convulsions of brain pathologies, they are presented in this group. And hydrocephalus is a major problem in brain tumors. In this study, the majority, about 63% of the patients are having hydrocephalus because most of the tumors are infratentorial. And here we present the relation of the degree of the resection to the outcome, and we could achieve total resection in about 50% of these patients, and subtotal in 37. We don't like to proceed to subtotal unless there are causes that prevent the surgeon from achieving complete resection, like attachment of the tumor to vital structures, vascular or neurological. And this is the histopathological types, and you can see that medulloblastoma represent about 30% of the patients, and others astrocytomas, hemangiomas, hemangioblastoma, and pilocytic also astrocytoma is a great contributor in brain tumors in the pediatric group. There are also other tumors like craniopharyngiomas, ependymoma, and many others. Here are the complications encountered during the management of these patients. It includes respiratory failure in about 9% of the patients, and hemorrhage in some patients. Infection also, not so much, and other problems like convulsions, like blindness and difficult walking, and many other complications. And the total the last outcome of these patients that is cure in about 25% of the patients, and improvement in 55% of the patients. There are mortality in about 16% and deterioration in one patient. These are some cases, some of my cases. This patient is 6 years lady. She presented with headache, vomiting, blurring vision, disturbed gait for a few months. And you can see here the CT scan showing fourth ventricular lesion, partially cystic and associated with aggressive hydrocephalus. You can see the third ventricle is ballooned, and the other image is post-operative. This also another patient. She is 7 years girl, presented with headache, blurring of vision, and unsteadiness. And she was operated first by shunt and then tumor resection. And you can see that she was operated about maybe 16 years ago. And the history came as medulloblastoma. You can see in the MRI that the tumor is just in the fourth ventricle, is not so large and associated with some hydrocephalus. And she has been exposed to radiotherapy session, and this is are the you can see in the bottom of the images the post-operative and follow-up MRI. It was only containing the fluid CSF in the fourth ventricle, and the lady, she's look very nice after long-term follow-up. You can see here this boy also presented with partially cystic and partially solid tumor in the fourth ventricle, and that is operative. We can operate on it and take it totally. And the history was pilocytic astrocytoma, and the patient was followed for a very long period, and he showed good outcome, and no recurrence of the tumor, and but he complained from the shunt and has developed shunt penetration after shunt calcification. Here is this young boy also presented with fourth ventricular tumor. Although it looks cystic in the first or initial CT, but you can see the sample as a left side. It was solid one, and the tumor has been taken totally. The patient has some infection, but has been treated from that. Unfortunately, I cannot operate the video to show you he is walking normally without any problem. And this also 6-year young lady presented with headache and blurring vision, neck pain, vomiting, unsteadiness, and shunt and tumor resection were done. The post-operative CT, you can see it looks okay and no problem. This is another patient. This is the same patient. I think the same patient. After no, this is another patient presented with blindness and hydrocephalus, and the MRI and CT scan showed fourth ventricular tumor, which has been taken totally. The patient was okay in follow-up, but has only still has residual blindness. The management strategies adopted by us are early diagnosis as much as possible. In any patient with vague cranial symptoms, you have to proceed to do MRI in the pediatric group, and so as to interfere early, and family support and help to take the right decision. And hydrocephalus usually has priority. Hydrocephalus complicates things in brain tumors and makes the operation difficult and highly liable to develop complications like CSF leak, like wound dehiscence, and like infection. And so hydrocephalus is not needed at all at the era of the resection of the tumor. You should work on relaxed brain. And maximal surgical resection with great care to preserve normal brain tissue. And aid of the microscope is very essential. Neuronavigation, CUSA, and microsurgical set. Anesthesia and ICU team should be expertise and familiar with these patients, and adequate blood and fluid replacement. Early physiotherapy and mobilization is a must, and multidisciplinary team approach in the help of pediatric neurologist, neuro-oncologist, neuroradiologist, and pediatric psychiatrist. And adequate long-term follow-up for any physical, mental, cognitive, educational, or social disabilities. CSF diversion is a priority in cases of presence of clinical or radiological features of hydrocephalus, so as to relieve the symptoms and to operate on a relaxed brain and to guard against future hydrocephalus due to recurrence, infection, adhesions. We prefer to do VB high pressure shunt either in the same session or in separated sessions. And we resort sometimes to do ETV or EVD in some patients, but we have seen many problems with ETV in managing these patients. We do not remove shunt unless it causes problem. Some people ask about this. If it causes problem, you can have seen that the patient who was operated at 7 years and came at 17 years, 10 years later with shunt calcification, and we do for him later on ETV and shunt removal. So to conclude, pediatric brain tumors are among the most challenging neurosurgical problems, and the management needs a stepwise multidisciplinary team, and the lesion tend to be mostly infratentorial. We have some patients who are supratentorial, but they are rare. And they are usually presented with hydrocephalus, and hydrocephalus present the main clinical presentation in these patients. In our center, it is found that two-step surgery, first with VB shunt, followed by a second tumor resection after a few weeks, is both effective and safe, with apparently good outcome. Thank you.
Thank you very much for this excellent presentation. I'm sure there are some questions in the audience. Anybody with a question regarding all the papers presented by our colleagues? Professor Wabi.
Thank you, Professor Darak, for your presentation. My question concerns the additional treatment. It's about chemotherapy and radiotherapy. What's your strategy during managing the tumor in pediatric cases?
You mean to start with chemo or radiotherapy without?
It's about the strategy in management of the tumor in pediatric population. You have to add some additional treatment as chemotherapy and radiotherapy.
Yes. This has
needed.
been.
What's your strategy?
This has been used in our studies because we know that there may be some residual tumors, and especially in medulloblastomas and astrocytomas, the malignant tumors. But the radiotherapist or chemotherapist usually needs histopathological diagnosis. And so we proceed to surgery first to provide the histopathology, so as that to adjust the chemotherapy or radiotherapy accordingly.
Okay. Yes, Professor Wabi.
I want to make a general comment on this session, very interesting session on pediatric neurosurgery. I think that the three speakers present very nice talks. Sanusi draw our attention regarding the hydrocephalus. All of us treat hydrocephalus, but the way he has been interested in hydrocephalus is very, very important, because sometimes, okay, there's a dilatation. We know that maybe the tumor has some problems, but if you go further to understand what is going on, so even in developing country, hydrocephalus not just chanting. We are trying to make some progress to knowledge, to understand. It's very, very important. The presentation of Professor Drag show what it's going on in some countries, pediatric tumors. So Africa is no more just myelomeningocele or hydrocephalus, but you have a lot of pediatric cases like you show, and you need to take care of them. And happy it's the neurosurgery in these countries are moving, and this morning we had a very nice session on vascular also. So something that has interested many our youth interested. The last presentation is Professor Shellawi show also the difficulty how to take care of the craniostenosis, which is one of the most challenging cases. So my comment is like that these are subspecialties that should be developed. Pediatric, neurosurgery, vascular, and we show that some progress in our countries, and I'm very optimistic for the future. This is just my comment. Thank you.
Thank you very much. We share your comment. It's very important to acknowledge that. Any other question? I see that we are late in the afternoon. Everybody sort of would like to relax a bit. But thank you again for the speakers. It was a fantastic session. Congratulations. Thank you for everyone for being here. You wanted to ask something? Yes, please. There is an announcement.
So thank you all for this wonderful day, the first day of the 13th course. And just to announce that we will have a dinner today, so please do not leave. And for tomorrow, a dinner in a few minutes. And tomorrow we will start earlier at 8:13. Thank you.
Thank you very much.